are you?
Fine, Kathy. How are you?
I'm doing well, thank you. In our recent video series, we've talked about a lot of great practices that improve patient outcomes, but there's one extremely important set of practices that we've not yet shared. It's one that begins before practitioners ever see their first patients, and it starts with a mindset, and discussions begin in undergraduate and graduate degree university programs. It's the belief in and the implementation of the interprofessional education collaborative competencies. And these competencies are the foundation for healthy conversations, enhanced team-based care of patients, respect, and a unified approach to working with other healthcare professionals. Now, John, I know that our education in our respective fields occurred before these structured competencies were developed in 2009. But can you share what you see as the value to having competencies and the benefits of having university students work with these competencies prior to receiving their higher education degrees?
Oh, absolutely. And I think the main thing that people need to do, even as it relates to what it is we're talking about today, is download the information as the IPEC got together, what they did, why they did it, and at least look at the pages in terms of put it in writing. Pages 8 through 19 will give you some idea of the complexity of what all these professionals have done to provide an extremely encompassing view of the types of things that benefit teamwork and how the outcomes are extremely beneficial for patients. And I think that's the first thing they should do, and then look through here as we go through some of the four core values that we're going to be talking about today. Look at that, and then definitely download. I think it's Appendix C, which has to do with the vocabulary. And that's pages 31 through 37, because each group has operational definitions of what they mean by this. And I think it's extremely helpful for students who are even undergraduate or graduate students to look at this and review this document in terms of why everyone is collaborating to make the system better. So I think, having said that in the beginning, I think it's an extremely valuable process, and everybody probably since the beginning of time have been doing something to improve the efficacy of education.
Sure. Well, let me do this. I'm going to go ahead and I'm going to share my screen.
Okay.
And let's go ahead and do this real fast. Takes a moment for it to download. There we go. All right. So this is the actual document that we're talking about. And even though this process started in 2009, as you can see here, it was published again in November 20th of 2023,
Right.
Which is nice to know that they continually update this, and it is a moving document, and it's a live document, so that it can be adjusted as new professions add to it. So, John, let's go ahead and pull some pages. Which pages you talked about? Pages 9 through 13 and some others. So let's just pull those up for our viewers.
Yeah, pull up page 8 to start with, Kathy. I think that's the beginning of the outline of the process. And I think to understand how the process was started certainly provides a perspective right there, that part right there.
Okay.
And I think that's really important. You can look at the 4 ways or the 4 important processes and how they started to solicit and elicit feedback from both education and people who are providing, whether it's clinical practice, even as psychology or as in healthcare facilities. They sought and got a great deal of feedback on that, which means those are the people in the field. So not only those people who are teaching it, but those people who are practicing it. And I think that's an important part of how they got here. The second one, like any good research, they did a literature review in terms of what types of things do we need to look at as it relates to people who are actually in the field. What are the job functions? How roles are done both in an inpatient, outpatient basis, whether it's in hospitals, whether it's for physical therapy, whether it's for psychology, all that stuff in terms of what are the roles. So they did a good job of background of finding out what was going on. And then they kind of updated things in terms of what they wanted to do was ensure that those things that we were practicing in the 60s were improved in the 70s, 80s, 90s, I'm 2023, so they've taken a lot of information and made sure, at least are attempting to make sure that we get the best of the best there in number three and say, okay, that's what we're talking about, and how does this help people who are applying these skill sets? I think
Right.
probably even starting here, and I won't go there yet. Let's go on to number four. Then looking at modifications for how IPC and other people, and I like the concept of when they call people, everyone who's doing this is now a learner, which is part of an operational definition, and how everybody can work together. And I think that's valuable.
Yeah. When I look at number three,
Mhm.
John, when they say in an evolving field, science and most of our fields are science based, that's changing all the time,
Mhm.
and so I think this document has to be live. It has to be continually evolving for it to be relevant.
And I think that's what you were saying. I think the interprofessional collaboration is extremely important. And we probably have not done a very good job in the past in terms of at least bringing things together. I think for the most part, we've operated in silos, and I think anybody who's worked in the mental health field certainly knows the Joint Commission on Accreditation of Hospital Organizations. They know what JCO accreditation means, and that group of people has a whole set of values that relate exactly to what we're talking about here. They also has CARF, which is the certification of rehab facilities. So anybody who has to be certified to provide mental health services or services is probably going to be reviewed and accredited by one of those two large accreditation agencies. And I think JACO's been around since the 50s and CARF probably since the 60s or 70s. So both of those things have been around for an extremely long period of time that goes through some of the things that the IPEC is also doing. Hopefully, it's updated, and along with I think the SAMHSA, Substance Abuse Mental Health Service Administration, also has a number of tip manuals, which are treatment improvement protocols that highlight some of the very specific things that we'll get to when we're talking about values and ethics and roles of responsibility, communication. And I think the last one that what we're looking at here really is how is all this applied in the teamwork approach. So I think people need to get the big picture, and then part of what we're going to do is take the big picture and we're going to break it up from our understanding of what's going on currently.
Right. And you and I had a little bit of a conversation before we began in regards to this statement. All concurred that the 2023 competency and sub-competency statements should be measurable and adaptable for use by health and partner professions involved in interprofessional teaching and learning. That measurable piece is a hard piece for professionals.
We can
Would you?
measure, but we oftentimes don't know, is that measurement going towards the outcome of patient care, or is the measurement going to how well we're doing at bringing information together? And I think those are the collaborative parts that we can do an extremely good job of providing information and education. But if that education is not practiced, then even though we can, if you will, we can get credit for we're doing a good job of providing lots of education, but nobody's using it. That's it. So I think that's the bridge that we've been trying to to build since I've been in this field for about 50 years. Where's the bridge between academia and all those things that we believe to be true, but we can't quite get it in a practice that seems to work the way we think it should? So I think everything should be much like IPEC is saying, needs to be modified, collaborated, and worked at again, and don't quit working.
Yes. Yes, I agree. All right. So that was page 9, I believe. And you had or page 80, excuse me, you had a couple other pages that you thought were extremely important for us to visit before we
Are you talking
actually.
about the vested partners, that page? Yeah, I
Mhm.
think they did a fantastic job of soliciting and getting lots of people involved. And yeah, and this is how they did it, that page right there, which I'm
Right.
not sure that I was either attracted to the shape or the colors, but being that I'm somewhat simple, the colors really got me. But everything that they did everything right, or
Yeah.
they're doing everything right. I said, I don't know anybody who could disagree with the process by which members were solicited and how they involved. I mean, they did everything perfect. So the fact that you may be able to challenge the concept, I think what IPC is doing is the right way to do it. So there's no doubt about that.
Yeah. It was extremely detailed,
Yes,
and you can
yes,
tell, and well thought through.
yes.
Okay. I'm going to drop, and you liked page 10. I
Yes.
know.
Yeah, I really liked page 10, the guiding assumptions. Go back the other way. You're one too far down. Go the other way.
One down.
That's,
Okay,
that,
right there.
that part right there. I think that's really important. The companies should include all of those things, and we'll just quickly go through that. I think the hardest part when anybody goes to a hospital and gets treatment is the concept of advocacy.
Yes.
Advocacy, and I think oftentimes we miss that because we do have a tendency as professionals to think in silos, and we don't necessarily coordinate our care between, if you will, between nursing and physicians and case managers and all that stuff. But I think it certainly is good as the one of the first guiding assumptions to say that everyone needs to be advocating for patient care. And I think that's the first one, and that's the one I really wanted to say was important. And all those down there, obviously, it needs to be community population oriented. The nature of the relationship, the nature of the process. That the next one is also an interesting one in terms of linked to learning activities. That's what we were talking about earlier in terms of everyone needs to continue learning, and then while and as we're learning, it also needs to be applicable. And I think that's the part that always seems to cause the problems in terms of oftentimes education or academia is probably a good, all the research seems to indicate a good 17 years ahead of when research is published before it becomes some type of generally accepted practice. It's been 17 years for the last 50 years. I mean, we knew that in the 60s when something is published, it takes 17 years before it becomes a generally accepted practice. That information was published again in 2023. It's still the same way. And I think that's speaks to how complex the problem is, how diverse the background is in terms of people providing this. And everyone agrees that everything should be outcomes driven because that involves patient care and we want people to get better. But I think it's going to take an awful lot of awareness, even, I mean, with this as a driving group, to make sure that we achieve the goals that we wanted to do.
When you think about young healthcare professionals and this emphasis on advocacy, I know that when I've worked with young professionals, straight out of school, I'm going to save the world type attitude, which is a perfect, wonderful attitude. However, that advocacy piece is hard because I think everyone in their respective fields feels like they need to advocate for their respective field, and really needs to, they've got the answers, and it's hard to compromise. I think when you're sitting around a table, working with a family or working for a family, so that advocacy piece, as they work in higher education, I sure hope that they're talking about that kind of mutual respect, as well. That you have to respect all of the health professionals around the table. And we'll get into that a little bit, I think, when we talk about roles and responsibilities further down in the document.
Well, yes, I certainly agree with that. When I was young and extremely idealistic, and now I'm just old and idealistic, that some of the things that I believe to be accurate or true in the 60s, certainly related to patient care. And because we had a bunch of old fuddy-duddies in the state hospital system, some of whom were like 30 and 31 years old, and they certainly, in my opinion, had outlived their prime when they were 30 because they weren't near as smart as I was, or at least as smart as I thought I was. And then as I got a little older, I figured out that they were probably a lot sharper than I was. So some of that has to do with that transition of how do I blend my idealism, which I'm fresh out of school, and I have all these wonderful ideas. How do I get this huge boulder to move towards what it is that I either believe and know to be true, given the fact that we're all firmly convinced that we're probably doing it the right way. And what you said is that we have to be professionally respectful, that we have differences of opinion, but we certainly all have to work together. So I agree with you on that part.
And I think as long as they stay family centered, which is that very first piece there,
Yes.
and then we're all in the right place, in the right space.
Mm-hmm.
All right, you had a couple other things here that you liked, and I think it drops a little bit, or that you thought was.
Well, I think there was. I think the hard part of even the gaps and additions, the section right back there, we kind of, I just alluded to that, and that's on the page 11. The gaps and additions Um, for years, we talked about patient care as people that if we couldn't meet their needs, were falling in the gaps. And it seemed like forever the people that caused the greatest difficulty were the people who quote fell in the gaps.
Mhm.
And we look back and say, well, why did they fall in the gaps? It's because we didn't have groups like IPEC talking about, okay, how can we fix the problem? I mean, back in mental health, we had the Department of Mental Health, we had the Department of Developmental Disabilities, then we had the Department of Substance Abuse, and oftentimes we had patients who had multiple problems, but by virtue of not being able to collaborate and pull all these groups together, patients fell in the gaps because we simply didn't have an overall view of how best to treat the patient. We could only treat a diagnosis, and I think this group certainly has addressed some of the gaps in that, and those gaps needed to be further broadened or included to make sure that we get the best possible outcomes for an identified patient, not necessarily for an administrative category, but for a patient who needs care. So we may have to work inter and intra agency relationships need to be questioned so that the outcomes are what we're looking for.
And those intra-agency relationships begin before they ever sit down at the table to talk about families, or patients. That's things that happen through email. It's things that happen through all your conversations. Even sometimes not just necessarily professional conversations, but personal conversations, as well. Getting to know the other people that you are working with, and getting to know them personally, and so that you have a better understanding of the decisions and things that they're making and the conversations that they're having too.
Yes, and I think what IPEC is talking about here in terms of people being a continued learner. I think anybody who ends up with a professional certificate or degree or licensure understands the concept of CEUs, continuing education units, that you need to constantly updating your professional skills to stay current with what patients need. So I think that's a big part of it. You need to maintain your licensure status, which means continue your education as long as you're in the field.
Yeah.
And that's a good thing.
Yeah. And John, I think you have a couple more pages that you really wanted to stress before we jumped into the actual competencies. What do you have that you'd like us to move to?
Well, I think the next one we then really was page 15 that highlighted what the core competencies were. We kind of jumped past that, and they can read that. I mean, that's good, but all the way to 15, I mean, how they got there, all that's okay. But when we got to what exactly are we talking, the public comment was excellent.
Yes, I do. I thought that so as
Yeah,
well.
that was kind of what I was looking at in terms of a lot of people had a lot of opportunity, and public comment oftentimes is not solicited by us people in professional education. I said, well, ask the people who know what's really going on. I mean, ask people in a mental health center, ask people in a hospital, what can you do? And who do you ask? I said, well, get that. And then the executive board obviously considered that in the development of these documents. So I think
Mhm.
that then really is where we got to the beginning of talking about the next page. Page 15 is where you and I really were. Now that we've kind of done the introduction for the last 10 or 15 minutes or whatever it's been, we're to the point where we're actually talking about what's version 3 of the core competencies, and that's
Mhm.
where I can talk about some of this stuff.
Okay. All right. So what I'm going to do here, let's come back for a second. And I'm going to minimize that for a moment. Pull some lens. So you want to go ahead and delve into those actual core competencies now?
Sure.
Okay.
I can talk. Yeah, the values and ethics.
Mhm.
That was the first one that we had as part of the 4 competencies. That's the first one. If somebody has downloaded this and put it in printing,
Yeah.
so they can look at it.
And before you do that, John, let's, if you can, we know that health professionals have worked with these documents probably a lot, hopefully in their undergraduate, their graduate work, clinical work, as well. So I thought it would be helpful to look at these competencies a little bit differently,
Okay.
through kind of a seasoned practitioner's eyes. You see, I didn't say old. didn't say, I said seasoned,
Good to be old.
practitioner's eyes. So when we walk through these, we're going to take them a little bit differently. If you can, talk about examples, real experiences, where you've seen the need for these practices, and maybe how a situation could have been improved, if the core competencies had been implemented. Does that sound like a way to approach these?
Yeah, sounds like a way to get me in trouble. No,
It,
we
it,
no, we could, yes.
it might. All right, so I'm going to go to the competencies. I'm going to share my screen here again. This is just a little bit of a pain the way that they go through these. So, all right. And I'm going to move this here. All right. So as we go through these, John, I'm going to share the screen. Your screen. Sorry, there's 1,000,001 buttons to get where we need to go. So when we come down here, let's just go straight to values and
16, I
ethics.
think 16 is the page you're looking for in terms of values and ethics.
There we go.
Yeah.
All right. All right, John. So I'm going to talk. I'm going to go ahead and read these because I think it's important. I know you're going to stress 3 or 4 of them. But I'd like to go ahead and read through these so that everyone gets exposed. If they've not had any experience with these, we may have paraprofessionals, we may have other people that are listening to our presentation here, our stream. But first of all, values and ethics are really about working with team members to maintain a climate of shared values, ethical conduct, and mutual respect. And we talked about that a little bit earlier. When you're sitting in a meeting and you're trying to advocate for a patient, I think sometimes that understanding that we have shared values and that we're working towards the same goal is something that can kind of fall off the table. So the first one, values and ethics 1, says to promote the values and interests of persons and populations in healthcare delivery, One Health and population health initiatives. And you go ahead and jump in where I know you've got some experiences and things that you're gonna share with us. But 2 is to advocate for social justice and health equity of persons and populations across the lifespan. 3,
I think a couple of things, Kathy. I think if people will put this in paper, all the bold print items, like if you back up, like where it says team, that means that word specifically, the word team, is in the vocabulary. I mean,
yes.
You need to figure out what team mean, or like in VE1, what's persons, what are populations, what's One Health. I mean, there are specific definitions that IPEC is looking at, and I don't think you can really understand the depth of the work that has been conducted unless you go to the definition. And,
yes.
and I'll give some examples in terms of, we go through this in terms of, obviously, number one is unquestionable in terms of, obviously that's what we're trying to do. Of the people in the populations, if someone comes into a hospital and they have a disease set or whatever, there's usually some type of emergency room admission process. The emergency room physician and social worker does not have the same priority after they've done the triage as someone who may be, a psychiatrist or a social worker. I said, but you have to understand, how do I hand off successfully from here to here if we are indeed looking at taking care of this person? And that's a hard one, because there are so many people who have so many things that they need to do in a certain time span, that oftentimes, unless we bring these groups of people together intermittently, say, here's where we fumbled. In football, who the guy fumbled. He's the only guy that's the ball carrier. So, but that's also the reason that he fumbled. I mean, obviously linemen can't fumble. So, but the whole team is contingent on everyone doing their job. And I think that's what this, if we're talking about the VE1, you have to take care of the people and the population, how it's being delivered, who's doing it, and why. So I think that's the whole concept between values and ethics of one. I think every hospital has an ethics committee. I know in the early, late part of 1960s, I was on the hospital ethics committee, where we reviewed interagency state hospital programming. We talked about who can do what differently, how can we do this, how can we do that. And we tried to resolve problems with people. Obviously, like you mentioned, some people who'd been in the system for 40 or 50 years, and people who'd been in the system for a year or two. So we had to resolve some of those differences. In terms of, one of the first things that we looked at was, who and when do people account for medication distribution and administration. There were some questions in terms of who had access to the medicine cabinet, who was supposed to, because in reality it was only supposed to be nurses, but intermittently somehow or another a certain amount of medication was always coming up missing, and the nurses didn't know how it was happening. That's because other people had keys. And that was one of the things, on an ethical responsibility. We had to make sure to safeguard the system, to make sure that patient care was okay. And that took a considerable amount of time, because we hadn't identified the problem. We didn't know it was a problem. So that became a problem that was fixed as a result of people working closely together to say we need to do something about that. And that was only brought up as a result of the hospital ethics committee. It was brought to our attention.
Yeah, and in number 3, uphold the dignity, privacy, identity, and autonomy of persons while maintaining confidentiality in the delivery of team-based care. That's hard to maintain that confidentiality, but uphold dignity, privacy, and identity of persons. Is this where we kind of remove our personal feelings, and things, and talk specifically about behaviors, about the outcomes, and actually the problem at hand?
Yes, and I think what's happening right now, because we do have HIPAA, and HIPAA is one of the probably the greatest misunderstood or misused concept. That people throw the word HIPAA around, that means I can't talk to you. That's not what that means.
Right.
In terms of, that was never the intent of HIPAA, for people to share clinically significant information. It was to share clinically significant information in an abusive fashion. So there are plenty of ways that people should be looking at, how do we work together as a team without throwing the word. And usually, in my experience, people use the word HIPAA almost as some form of a club, or some form of a way to get my ego needs met. Well, I can't share that with you, mainly because I don't want to, but I can say, well, it's a HIPAA violation. I said, no, it's not. What that means is we need to collaborate better, because we're both after the same outcome. So there are ways that we need to address, like you said, some of the personal needs of people. And I hope everyone has an ego. I mean, that's kind of what makes the world go around. But at the same time, when you're working in a team atmosphere, you have to set your personal interests aside and say, well, what's in the best interest of the patient? And oftentimes, now you've worked in the school system, the school social worker has to work with a school psychologist, who works with a parent, who works with a guidance counselor, who works with this. I said, that's all essential.
Mm-hmm. Mm-hmm. And 4, value diversity, identities, cultures, and differences. And this is huge, both with working with health professionals and working with patients. John, where have you seen this this competency kind of fall apart before, in a team-based setting? Or how have you seen it used well, where people have practiced valuing diversity, identities, culture, and differences?
Well, I don't think we had that. I don't think we had that problem. Definitely in the 60s and 70s, 80s, the biggest diversity types of issues we dealt with at that time probably was language barriers. We had a number of people who would come to either community mental health center or something like that, who hadn't been identified, if you will, as a diversity population. My background obviously is in working in a small rural mental health center, where almost everybody would meet the category of a diversity person, because they were all impoverished. We were in a federally designated medically underserved area. We did not have a physician in the county, and we were also a federally designated poverty area. So almost all the people who came to us were impoverished. They had limited means of income. We didn't even know probably didn't know what political lines that we had crossed when we provided care to people who were, quote, not in our catchment area, whatever that meant, because they showed up in your office. So you provided the care because that's what you needed to do with that person. And so I think it works when you don't know it's a problem, until someone points out to you, you shouldn't be doing that. Somebody else is supposed to do that. I said, but there isn't anybody else in our county who does that. And I can say when we lived in a small rural area like that, the sheriff would call me, and it's kind of somewhat humorous. He would call me on the phone and say, "John, I have one of yours." And I didn't know exactly what that meant in terms of a diagnosis, but anything that he couldn't deal with because he didn't know how to deal with someone who may be somewhat mentally ill, he just called and said, "It's one of yours. Take care of it." And even though I may or may not have the funding to do that, or I certainly didn't have the responsibility on multiple occasions, and I'll give you one example that the sheriff contacted me at well after dark because he said he had a suicidal patient and he thought I should address the issue. And I said, okay. So he said, well, get in the car with me and we're going to go check out this suicidal person. And I said, okay, because I thought that was well within the purview of what I was supposed to be doing in a mental health center. So we went out, and it was the middle of August, and we went to a cornfield. It was out pitch black. And he said, okay, he's out in the middle of the cornfield with a shotgun and he's going to kill himself. And then here's your flashlight. Go check him out. And I'm going, stop. Okay. I certainly understand that the person may be suicidal. He also may be homicidal.
Right.
Giving me a flashlight is probably not the best intervention strategy for me to engage in this particular gentleman. I said, now, if you want to go get him and bring him back to, the sheriff's office, I'll be more than happy to see him in your sheriff's office, but I'm not willing to take the risk to go in the cornfield, which is over my head after dark with a flashlight, not knowing whether the person was suicidal or homicidal. I said, but that was one way that we certainly looked at, the diversity. Obviously, the gentleman at that point didn't even speak English, so we don't know quite how he got to our county, but we certainly were able to take care of him at that point, and then got him to a larger town that could deal with someone who, at that point, I think was European at some level or another. So even though we may have done crisis intervention at that point, quote, we weren't being paid to do crisis intervention. I certainly wasn't being paid to chase someone who could have been homicidal through a cornfield. So, I mean, I think that's one way that we didn't even identify those people as diverse and different than anything else. Anybody that came through the county was available for some type of treatment option, and we were responsible to take care of it. Now I think that's changed.
I'm sorry. When we look at 4, value diversity and identities, cultures and differences, you can see why this document from 2009 to 2023 needed to evolve. The identities that we respect and recognize now, it was very different, back in 2009. So the evolving document, I think, is extremely important that these groups continue to meet and update this, as things change in our culture. And 5 was value the expertise of health professionals and its impact on team functions and health outcomes. 6, collaborate with honesty and integrity while striving for health equity and improvements in health outcomes. 7, practice trust, empathy, respect, and compassion with persons, caregivers, health professionals, and populations. 8, apply high.
Let's go to 7 real quick, Kathy. I think one of the key things about how IPC is defining a caregiver, it's anybody who participates. Could be a neighbor. So I think we've certainly broadened the definition of usually caregiver was someone in a professional role. It doesn't have to be. It could be a next door neighbor who may be in the best position to give you information on how often does this person get out of their house after dark. So I think the expansion of that in a definition is very important.
And even the definition of many people in regards to family, it doesn't necessarily have to be biological family, that knows the most about that person, that patient. 8, apply high standards of ethical conduct and quality and contributions to team-based care. I think that's apparent. 9, maintain competence in one's own profession in order to contribute to interprofessional care. Contribute to a just culture that fosters self-fulfillment, collegiality, and civility across the team, and support a workplace where differences are respected, career satisfaction is supported, and well-being is prioritized. So is there anything you'd like to add to those, John?
Yeah, I think probably 8, 9, 10, 11, I'll just group in one thing when I think interagency cooperation is extremely important. because we have different biases. We certainly have different histories and background. When we first started what was called in the 60s the team approach, we had a number of occasions where the team, which included at that point it was our consulting psychiatrist who was head of the SIU Med School, would come to the adolescent unit. We had social workers, we had psychologists, we had mental health technicians, and we had case managers, discharge planners. We would get in a meeting and say, what's in the best interest of this patient, what for, how come? And we all agreed, or we tried to agree on what the outcome should be. And on one particular occasion, which I recall vividly, a particular patient of mine who had been in the hospital for probably a little over 9 months, I believed was ready for discharge because I had done a home study and I'd met with the parents. She was ready to be discharged and ready to be accepted at home. I had the Department of Children and Family Services involved. They were also supportive of her being discharged. The consulting psychiatrist was in favor of being discharged. And our administrator, who was obviously responsible for the ultimate decision, did not believe that the patient was ready for discharge. And so I said, okay, we have the two psychologists, DCFS, a consulting psychiatrist ready for discharge. What do we do? She said, well, it's a team, so we're going to vote on it. I said, I don't know what that means. I said, well, we're going to vote, so it's a democracy. And I said, okay, well, who's voting? Well, anybody on the ward. At that point, she went and got 15 mental health technicians from the ward, and we all voted, and the mental health technician, the administrator voted to keep her, and all the professional people voted to discharge her. So that was my experience with how a team should not work. Even though we kind of respected to the right to be different, there are some opinions that, in my opinion, are more valuable or more valid than other people's opinions. And the concept of a team is not a democracy. It's that we have mutual respect for mutual contributions to the welfare of the patient. And for the most part, I think that has improved. But that was one time that I certainly recall that that was never the intent of how a team was supposed to be. It's not a democracy. We don't get to vote on it. It's not that. I mean, we can certainly have conversation, but at some point, someone has to make the ultimate decision as what's in the best interest of this patient at this time. Obviously, always subject to change, but that was one of the probably the most memorable and uncomfortable experiences that I ever had related to a team approach to working with an adolescent.
Yeah, that just doesn't seem like that's a true team approach. All right, let's go to roles and responsibilities.
Mm-hmm.
And again, let's look at the definition here. It says to use the knowledge of one's own role and team members' expertise to address individual and population health outcomes. So you had talked about using the bold words to kind of really delve into these. So own role and team members' expertise. To me, John, that's looking like it's saying exactly the conversation that you just had. Was you have to look at those roles and those team members' expertise, but that doesn't mean that we're going to vote. That doesn't mean that we all hold our hands up and make big decisions regarding our families or regarding our patients.
I think that's the reason that it's really important that we educate our college students earlier, is that there is a role that you have, and this is the way that it should go, that everybody contributes something, and then collectively we come up with the outcome. It's probably not exactly democracy, because if we'd included the 50 janitors, they may have voted the other way. So, right. I mean, I think you have to be taught what is your role in the team. You're part of the pie. You're certainly not any larger piece than anyone else, other than obviously in any agency, there's a pecking order based on probably the amount of responsibility that you have towards insurance carriers and providers and things like that, which someone has to take the ultimate responsibility of making a decision regarding what type of care being provided. And generally that's the physician.
Mm-hmm. And even safety, patient
yes.
safety, as well, or family safety or community safety. So roles and responsibilities, one, include the full scope of knowledge, skills, and attitudes of team members to provide care that is person-centered, safe, cost-effective, timely, efficient, effective, and equitable. And that's a lot right there to consider. Right.
Well, at least two or three of those things probably aren't going to be established by the people providing the care. Those are almost administrative responsibilities.
Yes.
And someone's determining what's cost effective, timely, and equitable. that's probably a management decision that we may have to chew on for a while, because oftentimes people who are managing an agency don't always agree with the clinical outcomes that the clinical staff is doing. And I think that's really important to educate college students that the reality of the situation, the decisions we see are important, may not be agreed upon by administration.
And coming back to our values and ethics, I think it was number one, competency number one. We're taught to advocate, 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 advocate. And then you come back, and how disappointing this is sometimes for young professionals who don't quite understand the big picture of everything. That you do have to consider, what's cost effective, timely, efficient, effective, and equitable, as well. And that's hard to swallow as a young professional.
Especially when I'm right and they're wrong. I mean, that's always the hard part to swallow.
Yeah, and that's easy to feel that way when you're working with families that you have a vested interest in.
Yes.
So number two, collaborate with others within and outside of the health system to improve health outcomes. And it's exactly what this group did. Incorporate complementary expertise to meet health needs, including the determinants of health.
That's a big one.
Yeah, that's is a big one.
In terms of, I'm very fortunate to have a number of college students who do practicum settings here in the agency, and they have all been trained on how to do a mental status exam. And then when they do a mental status exam, that means they know how to do it as per the textbook. But when you start dealing with a patient, the patients don't have privy to the textbook, so they don't follow the outline. So you have to be at least flexible enough in terms of trying to determine what this person needs to wander around through the mental status exam, because oftentimes, believe it or not, mentally ill patients aren't always cooperative with a sequence by which you're trying to determine what they need.
Sure. It's real life.
Yes.
Incorporate complementary expertise to meet health needs, including the determinants of health we went through. Differentiate each team member's role, scope of practice, and responsibility in promoting health outcomes. And I think that's important. Do you agree, John, in differentiating each team member's role? One healthcare provider can't provide everything, every bit of information. We have to, again, going back to the values and ethics, we have to respect each person's role and understand that in this meeting, this is your role. This is the scope of your role, because you can't be everything to everyone as you're sitting in and becoming part of a team.
And I think that's probably the hardest one that we run into right there is roles and responsibilities number 4, in terms of the concept is that we all work together as a team. And that's true. At the same time, someone has to make a decision. And in this case, I would say, okay, let's say the case manager is responsible for collaborating and bringing people together. But even in an orchestra, somebody has to be the leader of the orchestra. Somebody, I mean, the orchestra leader doesn't play an instrument, but he certainly tells people, this is when you're supposed to do this. And then we can sit down and collaborate on, maybe I don't like this leader, I don't like the way your leadership team, but I think at some point someone has to say, this is your role here, and there's a lot of overlap between some of the things that a case manager does. There's a lot of things that a social worker does, that the psychologist does, and there's things that MSW. There's a lot of those things that are good for the team, as long as people understand that when we start developing our outcomes, we have to know what roles we're playing and why we play those roles. So I think that's really important to teach graduate students for sure, in psychology, social work, health education.
Yeah, and in order to get to a final product or a final decision, it's like I talked to you a couple days ago, John, about me having to go in with my aging Alzheimer's father and trying to make a decision on who receives financial power of attorney, who receives medical power of attorney, and those are hard decisions. But ultimately, one person, in order to move forward, has to have the responsibility to make that final decision, or sometimes the team doesn't move forward. Have you seen that happen where it seems like we're just not making decisions? when it comes to outcomes for a patient or decisions on patients?
Well, yes, I think that's a legitimate problem because the whole concept between what it is that we're talking about here is that people need to communicate, and this is the process by which we communicate. But now, what we communicate in terms of who's going to follow through and make sure, okay, everybody agrees that this person needs to get to the hospital. Well, how do they get there? Well, the ambulance can't do it for this reason. This, I said, okay, well, who makes that decision? Can I call an Uber? Who's going to go with them? Well, I'm sorry, the social worker can't go with them, the psychologist can't go with them, maybe the case manager can't. No, that's out of my job description. I said, well, then we have a problem here. Maybe we need to call a care worker, which may be a next door neighbor or somebody else, but someone has to be leading the orchestra at that point. And oftentimes, the only time, in my opinion, when you run into problems is when we don't know who's supposed to do what to whom and why. We can talk about it, and within the confines of this office, I pretty much know what I'm supposed to do, but someone could come in and tell me, no, that's not what you're supposed to be doing. I said, well, that's a different issue. But oftentimes when we're talking about these things, we miss what the roles and responsibilities are because they change from agency to agency. And I think students need to be prepared for what your role was in this agency is not the same thing as in this agency, but you have to go with what the agency determines your role is.
And flexibility, like you mentioned earlier, it's just absolutely key.
Mm-hmm.
And then 5, you see this kind of as a theme across all of the competencies, practice cultural humility and interprofessional teamwork.
Yes.
All right. Let's look at communication. And let's see here. The definition or the overarching theme on this one is communicate in a responsive, responsible, respectful, and compassionate manner with team members. This is really about being on your best behavior, and I think pretty much, but I love that they added a compassionate manner, because you can be extremely compassionate and not be respectful as you're sitting as part of a team, or you can be compassionate in a very respectful way of the rest of your team members. So when I look at C1, is to communicate one's roles and responsibilities clearly. I think it's important that everyone at the table understands what your role is and what your responsibility to that patient is, because that really allows us to try to make some decisions on who's going to make the final decision and gather all of this information.
Yeah, I think that should be in someone's job description in terms of what it is you're supposed to do, and then if we disagree on who's supposed to take it, then at least we have a manner whereby we can debate that. Okay, but this is what I'm supposed to do. Somebody please clarify for me, and I'll be willing to change that as long as you treat me with respect. And that makes sense.
Yeah. C2 is use communication tools, techniques, and technologies to enhance team function, well-being, and health outcomes. 3, communicate clearly with authenticity and cultural humility, avoiding discipline-specific terminology. And I've sat as educator in, for example, team-based meetings, RAP meetings, or IEP meetings, where we use a lot of discipline-specific terminology. And I think that's important, not just for other people on your team, but our families as well. How often do we talk in acronyms, that some people don't understand? And some of those are discipline-specific. We have to make sure that we bring that terminology where everybody can understand what your roles are and what you're trying to communicate, I think. Promote common understanding of shared goals. And I've seen this work so well, John, and maybe you can talk about this too. When somebody at the very beginning of the meeting says, is this our goal? Lay it out there and say, do we have consensus here that this is our shared goal for our patient? And it seems to work extremely well when the team can go back and say, wait a minute, this was our shared goal. This is the goal of this meeting. This is a goal for this patient. And you have something to kind of come back to when a team gets off task.
Yes. I call that mission creep. Oftentimes, even though we start in one place, the mission seems to creep this way and that way. And I said, wait a minute, that's not what we're trying to do here. let's go back to where we're going and in terms of what we agreed to in the beginning, because oftentimes it's been my experience that a meeting will fulfill the time allotted. I said, that's not what we're after. We're trying to get the best possible outcome as quickly as we can. And definitely we can debate it. I said, but sometimes if I've got to fill an hour meeting, the meeting seemed to last 59 minutes and 59 seconds. I said,
Yeah. Yeah, I've seen that happen quite often in meetings. Practice active listening that encourages ideas and opinions of others, team members. You know, that active listening, I hear you saying, you know, and repeating and trying to use the best active listening skills that we have. But to do that, to encourage ideas and opinions of other team members, I think it's extremely important, because, you know, I've sat in meetings before where it seems like the conversation is going between two people, and the rest of the team sitting back and feeling like they can't express, or they're not being given an opportunity to speak. So, what do you see as some of the best active listening skills that our young professionals, you know, people getting right out of school, can use?
well, there are a couple of things. I think, first of all, you can thank Carl Rogers for the concept of active listening and say, thank you, that's what you're supposed to do. So, I mean, anything that goes back to old Rogerian therapy that says, you know, what about that makes you feel this way? Or what about that? What are your ideas? Is solicit everybody's opinion. Don't leave anybody out, even the quiet ones. There's a reason you're there. We need your opinion. Sometimes the person who's probably has the most valuable piece of information is the quiet one and needs to be solicited. So I think active listening is soliciting everyone's opinion on what's going on, and then we make the soup after everybody, you know, says something. But I think everybody needs to be encouraged to participate in team meetings, and obviously when you're in graduate school and you take classes in group dynamics, and you study people like Dinkmeyer and Durrell and all the people who did a lot of that active listening stuff. I said, then that's just a good basic way to include everybody.
Mm-hmm. Use constructive feedback to connect, align, and accomplish team goals. And I like that the word team again is in bold. But the other word here in competency C6 is use constructive feedback to align, bring everybody together, again, so that we're all working for the same outcome. And then C7, examine one's position, power, role, unique experience, expertise, and culture towards improving communication and managing conflict as well. So, you know, we have to know kind of what our role is, and then we talk about that in roles and responsibilities, making that clear at the very beginning. But what is my position? Am I clear on my position at the close of a meeting? Do I understand what power I have to make decisions here? And, you know, again, it comes back to what is my role in this actual team meeting? So talk about that a little bit, John.
Well, I think the unique thing about even that statement right there is that obviously we have a lot of different changes in cultural approaches to things. We have a polyglot of people who obviously are coming to the country more and more. It's not just people who so much don't speak English or do speak English or Spanish or something like that. Even within the English speaking culture in the United States, we have 13 different subsets of culture that have cultural values. The Southwest doesn't think like the Northeast, and they have different values. But I think that's the part that this is referring to, that we have cultural differences, and how you bring that cultural difference to the table to improve communication is the skill set. And that's where it goes all the way back to the first one in terms of respecting people's differences. It's not one's better than the other. It's that we all have some value. Let's see which one has the greatest efficacy in achieving back to our what is the team goals.
Mm-hmm. Good. All right. So we finished communication. Is there anything else that you want to talk about there, John?
No, I think the good part about communication, I think it obviously it varies if it depends on how you communicate, but if you start out at the right place, it may vary based on the intensity. And I think if people respect that, I have a civil engineer friend who who does lots of things working in Florida, and his favorite expression is it's very difficult to remember the objective is to drain the swamp when you've got alligators swimming all around you. I said, well, yes. And sometimes you may yell, scream, and say things that are inappropriate, but it's very timely. I said, so as long as you respect the differences, I think there's a lot that leads to a successful outcome of a meeting by winnowing some of that stuff down and then accomplishing what you're trying to do.
All right. So let's go on to teams and teamwork. The overarching theme is to apply values and principles of the science of teamwork to adapt one's own role in a variety of team settings. And TT1 is to describe evidence-informed processes of team development and team practices. What do they mean there, John?
There's all kinds of research on Eysenck and Duro and Dinkmeyer, and all kinds of people have done research on teams and the efficacy of how teams work. I mean, there's a considerable difference. Right? You can look at even something as simple as what appears to be a football team. Everybody has a different role, but there's only one ball. So the center hikes a ball to the quarterback, who gives it to somebody who's a running back, and he's got a role. But in order for the running back to do his job, somebody has to block or somebody has to do something else. I have a familiarity with a couple of young boys who were twins who played football in high school, and I had the advantage of working with both of them as adolescents. And one of them was a blocker who was a tackle, and the other one was a running back. And my son happened to play football with him, and they got in an argument in the huddle. And the one who was the runner was yelling and screaming at the guy who was supposed to be blocking. And so evidently the young man whose name was Joe, was upset with his brother, and the play was called to run by him. So he informed his opponent on the other side, is the play's coming this way, and I'm going to step out of the way, and you get to nail the ball carrier.
Oh my.
Which he did, which happened to be his brother. Mm-hmm. So that then prompted a discussion in the huddle, evidently, where they came to agree that they were going to get along and work better together without chewing one another out, because it didn't bode well for the guy who was the ball carrier if his brother didn't block. I said, that to me is teamwork.
Not at all.
At multiple levels.
Number 2, appreciate team members' diverse experiences, expertise, cultures, positions, power, and roles towards improving team function. How do you use, expertise I can understand, cultures I can understand. How do we improve team function?
I think that's by appreciating all the diversity that people bring to the table. It's really simple. There's a difference. Without all that stuff, you can have a group of everybody who came from the same town and born and reared at about the same time, and you just put men and women in a group, and there's diversity right there. We have totally different perspectives of how to solve a problem. Then you start sprinkling people from another town in there, and then you start mixing other people who are cultural difference, and people have different backgrounds, and people are, all that stuff is really, really important to improve a team function. And that gets back to really the previous one, where people have to cooperate.
Mm-hmm. Practice team reasoning, problem solving, and decision making. Use shared leadership practices to support team effectiveness.
That's a hard one.
Yeah.
In terms of, and because usually in a group of people, and group dynamics will tell you that at some point a leader is going to emerge, and those are usually the people who like to talk the most, but they may not be the most gifted. At the same time, people have to realize that probably someone needs to take some type of leadership role. But I think in this dynamic, in terms of teams and teamwork, people need to question that and say, okay, but that's not where we're going. Back to the previous slide that you and I were talking about, is that the team efficacy is totally contingent on trying to achieve an outcome. And I think the shared leadership is fine. I don't think necessarily you have to say designate a leader, but at some point the leaders will emerge. They always have.
Mm-hmm. Apply interprofessional conflict management methods, including identifying conflict cause and addressing divergent perspectives.
I think that's important in terms of a couple of things there, because the initial step in conflict resolution is what everybody fears, and that's confrontation.
Yes.
So you have to confront the issue. I said, I can confront an issue without confronting a person. So conflict resolution comes from this is the issue. So we need to talk about this issue from multiple perspectives if we want to resolve the conflict. So I think that conflict management comes from the freedom to address and what's causing that conflict, and that's the part that we were talking about.
Mm-hmm. Reflect on self and team performance to inform and improve team effectiveness. I think this is that self-reflection, after meeting one to improve meeting two sometimes, as well. Share team accountability for outcomes. TT8, facilitate team coordination to achieve safe, effective care and health outcomes. TT9, operate from a shared framework that supports resiliency, well-being, safety, and efficacy.
That's
And
significant because I think those are things that people feel but can't articulate. In terms of it is not unusual for some people to have said something in a group dynamic, and then someone may challenge that, and now they feel uncomfortable. So that means that we're not going to get any more opinion from them because we at some level have engaged in some type of, if you will, psychological bullying, because now we've lost a valuable input based on that. And I think that's what we have to recognize, that occurs. And
yeah,
I think when someone who's been speaking and then becomes quiet, and then at some level someone has done something to make them feel unsafe in that team environment.
right. And that's hard to get back.
Mm.
It's very hard to get back. And I think sometimes too, as we talk about, for example, undergraduates working with this document, they're not that far off of adolescence. Where things can be very ego-centered, and when you come into a team-based meeting, they're not that far off of that adolescence, and now you're looking at graduate work and clinical studies and those kinds of things, as people mature, it's a little bit easier. But like you said, once you seem to be, and it could be just self-perceived, if I feel like someone has questioned me in a way that that may have been hurtful, I may not be opening my mouth again for a while, and that's really not the best for patient outcomes, of course, because they could have lots of good information.
And the team loses.
The team
The
loses.
team loses.
And our last competency, TT10, discuss organizational structures, policies, practices, resources, access to information, and timing issues that impact the effectiveness of the team.
That is the quintessential role of management or administration. I mean,
Yes.
if you can't tell me what it is I'm supposed to be doing, then I probably won't do it right. But if you tell me what it is that how I relate to the organizational structure, then that tells me what part in the team I can play.
Right, exactly. All right. So, John, there are a couple more pieces in this document. I know we have the acknowledgments. I wanted to just show people references. I mean, look at that. You can tell the amount of study and work that went into these. The brief history of IPEC, they can look at that if they want. It just again shows the depth of the project. Programs, project, and resources is nice for them to be able to see. I wanted to get to not the leadership program, but to the actual, and we're getting there, to the actual glossary of terms.
Mm-hmm.
And I'm sorry for our people who are watching that they're.
You're talking about Appendix C?
Appendix C.
You're talking about vocabulary words in terms of how they defined it?
Yeah.
That's 31, page 31.
Page 30. Thank you for having that in front of you.
Mm-hmm.
Except that they're not numbered anymore. As you get down. Appendix C, there we go. All right, towards the back of the document.
Yep.
But you can see these glossary of terms. How important is it for us all to be talking the same talk? And we talked a little bit about those discipline-specific vocabulary and acronyms and those things, which really kind of shut down conversation. But understanding and using the same vocabulary is so important to the strength of a team. So just so that our viewers understand that this is all here. And there's a lot here, and I love that they give you, the definition of the way that they look at that.
And everything in the first part of the documents we're talking about in terms of pages 8 through 19, anything in bold print is in this vocabulary. And that's
Uh-huh.
what the bold print means. It's back here.
Mm-hmm. Yeah, good. So, any of our viewers that want to, as they get ready to sit on a team, coming back and looking at this vocabulary and making sure that you're using that would be an important first step and an important way to prepare to be an effective team member,
Yes.
as well. So, John, anything else in regards to, we've come to the end of our competencies, anything that you want to say in regards to this to finish us off?
I think it's really important that people know how to be on a team, how to join a team, how to ask questions in a team. In reality, in healthcare, I certainly subscribe to the idea that no man or no person is an island. There are so many diverse things that are happening so quickly in our culture because of the internet, because of things like that. I think it's really, really important to share information and get a hold of people who know more than you do, and say, okay, we're no different than you do, and that said, let's advance our knowledge. And I think the best way to do that is having more team meetings specifically related to patient care.
Right. And it takes a lot of time, and sometimes we're trying to get task by task by task done, and sitting down to another team meeting isn't always what we want to focus on.
Exactly.
So good. Well, John, thank you very
Yes,
much
ma'am.
for today. I really appreciate you taking the opportunity to talk us through this document and to give us your years of experience. Okay.
Thanks, Kathy.
Thank you very much.